Okay, perfect. Thanks, everyone. Hi, my name is Emily Woessner. As I said earlier, I am the eConsult contract administrator on the HCPF side, and we are here today to provide an update for you all. Okay. So this just looks at our vision for eConsult. So increasing access, equity, and outcomes for all Medicaid members by supporting primary care with specialist advice, improving care coordination and decision-making, expanding specialty care access across Colorado, and eConsults are flexible and reimbursable. So this is just an overview of what eConsult is. So Colorado Medicaid eConsult is a free web-based platform. Only a web browser and internet connection are required. No software installation is needed. Our platform also supports single sign-on and data integration with capable EHRs. This just looks at our available specialties that we have. We have 21 adult specialties still available to date and 16 pediatric specialties as well. We also offer OBGYN to adolescents ages 14 and up. And I'll turn it over to Dana, who's going to walk us through some data.
Thank you, Emily. I'm Dana Chang, evaluation specialist for the eConsult platform. And the data today we're going to share is from February 2024. That's the first month the program launched till the most updated data through last month. That's April 2025. So the bar chart here shows the monthly submissions from February last year to April 2025, and the utilization increases in July, August, and September. That's supported by the dedicated fund allocated to the RAISE to encourage eConsult utilizations. And we did see pretty good eConsult activities in those months. And after that has been stabilized to under 100 eConsults per month. And as of last month, April, we have a total of 928 eConsults submitted, and that include 261 pediatric eConsults, that's in the red bar. And for adult eConsult in the teal bar, that's a total of 667. Next slide, please. And this one shows the top 10 submissions by specialties. And just want to mention that for the available 21 adult specialties and 16 pediatric specialties, they all have at least one eConsult submitted in our platform. And the top 10 overall specialty, the first one is endocrinology, followed by dermatology and neurology. When we look into specifically for adult and pediatric, the top one for adult is endocrinology, followed by neurology and rheumatology. And for the pediatric patients, that's the red bar. The top one is dermatology, followed by psychiatry and neurology. Next one, please. This is the submissions by RAI and by county designation for the total of 928 eConsults. And for the blue bar, that's from the urban counties. That's the most submissions, followed by rural county, that's the yellow one, and the frontier, that's the red bars. And there are lower utilizations in RAI 2 and RAI 5, and that is because something we shared earlier, that RAI 2, we know they have Banner Health, and in RAI 5, there are Denver Health and UC Health. You're using the third-party platform. And next one, yes, thank you. For the eConsult outcome, there are total of 921 eConsult. They have a closed code available for PCNPs, worker recommended, face-to-face, or specialty change. And for those eConsult, 90% of them have provided actionable guidance to the PCNPs to carry out next steps. And that's 90% is the combine of the 636 PCNP management and 192 further workup recommended. So PCNP management means that the PCNPs has received clinical guidance to follow up next step. And further workup recommended means that additional assessment or lab work are needed. Face-to-face recommended means they need to see the specialist doctor in person, and specialty change means that the specialist recommend that condition is appropriate for another specialty. So the PCNPs will have to submit a new eConsult. And the average response time is less than 1 business day. So that's a pretty quick turnaround. And that's it for my update. I'll turn it back to Emily.
Thanks, Dana. We just wanted to let everyone know that we are hosting CME webinar series that are available to all healthcare providers in collaboration with ComforMed, which is SafetyNet Connect's virtual specialty network partner for our platform. The next one that's coming up is going to be on June 4th at noon, and the topic is update in diabetes management. And then we also have another one on August 14th for the assessment of liver function. So we'll make sure you guys get the presentation after today's meeting, and we'll also drop these links in the chat. Heather, I don't know if you want to do that now or wait, but yeah, we'll make sure you guys have access to sign up to attend these webinar series. And then we're still on track to go live with our specialty to specialty feature for July 1. So what's new? So as we've mentioned before, the role expansion. So current treating practitioner user role will be expanded into a generalized submitter role. We plan to add new fields to differentiate between the types of submitters. And then in terms of eligibilities, specialists who are MDs, DOs, NPs, or PAs will have the ability to submit eConsults as a submitter. And our overall impact is to continue to support our mission of improving access to support care for our members' well-being and facilitate the co-management of members with complex multi-specialty needs. And then this slide just goes over our steps to participate. So if you're interested, please email SafetyNet Connect at coloradosupport@safetynetconnect.com to get started if you're not already enrolled. And that's it for our brief presentation and update for today. Do we have any questions?
I was kind of surprised that the rural RURAL access hasn't been that strong. I would have thought it would be stronger, but then there's probably a less preponderance of providers out there, so that probably shows up in the stats. But I think the rural communities have a serious need for special for eConsults.
I just have a question about the raise because I'm not familiar with where each number is. And so I know it looked like when you went through that screen, there was 2 rays that had like, I guess, minimal eConsults. And I was just wondering which ray is Arapahoe County?
I'm not sure off the top of my head. Heather, do you know? Ray 5.
Ray 5.
And what was the number for that one?
10.
Was that one of the lower ones?
Yes.
Okay. Okay, thank
So
you.
it's like Colorado Access, I think right now is Ray 5 and Ray 3, right?
Yeah, Ray 5 is actually Denver City and County, and Ray 3 is Adams, Arapahoe, Douglas, and Elbert right now.
Okay.
July 1st.
So one of the reasons is it could be that the providers in those rays are already using alternate platforms. Or it could be, and we're going to be working, I think, closer with Colorado Access come this summer for those outfits, those providers that are not using it, the eConsult platform, or even underutilizing it. What can we do in Aurora Health Alliance to promote and get more providers on board with that? I think come July 1st, Ray 3 and Ray 5 it's going to become, well, under Colorado Access. Is it Ray 4 now coming up in July?
Yeah, it'll be Ray 4 and it'll be all the same counties except for Elbert. So it'll be Adams, Arapahoe, Douglas,
Right.
Denver.
And we've talked with Denise with Colorado Access, and they're facing lots of work to get themselves to July 1st. So we kind of put on hold our outreach as a health alliance to the providers that Colorado Access supports until after July 1st, get things to settle down. And we have a clearer picture of what the future is going to look like.
I have a clarifying question. What is rural versus frontier? I always forget. People refer to that all the time and I forget. I think that was Dana presenting rural and frontier slides.
I'd have to go back to like look at what the actual definition is because I'm not sure off the top of my head. But when I think of like rural Colorado, I think of like really tiny communities that don't have a lot of providers. And they're out in the middle of who knows where. And then Frontier, I feel like is more, it's like a bigger network, but not like urban which is huge.
Yeah, and just to piggyback on that, I forget the exact definition. Rural is further out, lower population, and then frontier is even lower. Like, I think like 10, I can't remember the exact definitions, and I don't know if it's a standardized federal definition or if it's by state. But frontier is less dense, I think, if I'm remembering correctly, and I would need to Google right now, than
Frontier sounds like the Oregon Trail, like a covered wagon, but
the first class frontier. I know we're focusing on Aurora right now, but we are interested partners, and I loved Rich's question about the rural areas. It just makes me it made me think of if you guys have been connecting with the practice-based research networks in the state. The Department of Family Medicine at CU partners with kind of a pretty robust practice improvement network that works on disseminating new initiatives into primary care across the state. And they have practice-based research networks in kind of rural regions and things like that. And so I just wanted to, I know you guys have been connecting with many different stakeholders to work on implementation and dissemination, but have you guys been connected with them in case they maybe have some connections or ideas on dissemination?
I can speak to just our connections in rural health. We've our most solid connection is with the Colorado Rural Health Center. So we did present to their stakeholder group last year. We'll be presenting again at their quarterly meeting coming up next week. And then we've been in a few of their newsletters. I think what you're speaking of, Carrie, if I'm familiar, is that Practice Innovation Program. Yeah, that did SIM. And I don't believe that we have made any formal connection, Emily, to that group, to the Practice Innovation program. I get their emails just from Chess and from my past life as a practice transformation coach over here at Rocky. So still familiar with who that group is. And if you think that would be a valuable connection, I think that would be maybe another way that we could get the word out. So Emily, I think it'd be okay if we get that introduction.
Yeah, I think if you're already connected with it, they might be helpful too, because they might be with clinics that don't classify themselves as a rural health center. You know, there's different classifications, and sometimes more private docs that still see Medicaid and things like that too. And then there, I forget what it stands for, but there's SNOCAP network. It's like state of Colorado, various practice-based research networks, which are some on the Eastern Plains, you know, different areas. They sometimes work within those, but might be helpful just on one meeting to run the list of who's engaged, and if they have additional folks you can reach out to. So If you already
Yeah, Carrie, we
but if-
welcome the introduction. If you have a key person, that'd be great, like you did with Phyllis. You connected us with Phyllis from Colorado Safety Net Collaborative. We were able to connect with her and present to her membership as well. Again, just our one of our main objectives with these, external stakeholders like yourself is to create this guiding coalition, right? And make sure that everybody understands that this is a free tool for them to access if they're Medicaid providers that supports them and their patients. So any way we can do that, we're happy to.
Great. I will send that email. And should I copy Emily on that?
Yeah, that'd be great.
Okay, I'll do that, Emily.
Well, just a question maybe to Heather or Emily. Are you, now that the eConsult platform has been live for over a year, are you getting feedback from providers of, hey, this is really great, I really like it, and from providers are saying you need to work in various areas? And I say that because as we do start our promotion, we would like to be able to address what providers uh, are saying about it, the good things and the things that need to be worked on, and then to recognize there probably are things that need to be worked on, and just to be upfront and transparent with the clinics that we're reaching out to that are not using any eConsult platform. So are you doing that? Are you getting feedback from the providers using the eConsult platform? And maybe in come this summer, you can share that with us so that we can compose an outreach that says, this is the reality of it. This works well. This we're working on to do better.
We are collecting feedback, Rich. So every time a provider closes an eConsult, means they acknowledge and sign off on it, they are presented with an optional satisfaction survey that also contains free text. And so our survey results have been extremely positive. We've also gotten a lot of verbal, feedback in those chats, as well as just through our communications. I reach out to providers pretty regularly in supporting them, encouraging them to utilize the eConsult platform. And all in all, the feedback that we've received has been extremely positive. I will also I'm going to put in the chat my Medicaid eConsult information site, where we do have some provider feedback just rotating on the homepage. And we do change that up every so often. We also include feedback in all of our program overviews. So when we meet with external stakeholders or interested parties, we do share some of that feedback. I think the biggest, one of the biggest barriers that we've seen in adoption is taking on something new, starting a new workflow, which Carrie's nodding her head as a clinician, physician trying to add something onto their plate, although at the end of the day, results in high quality action they can take, it's still an additional task. And so I think that's been one of the pieces of feedback that we've received is, I'm hesitant to start something new, or we just changed EHRs. I don't want to have to bring on, something else. And really engaging staff in the process has been one of the ways that we've overcome that perceived barrier. That's probably been our biggest barrier. We've also had a little bit of challenge with some of our larger organizations, just administratively connecting with these larger groups, and do they want to take it on as a large health system? Do they want individual practices to just go ahead and hop on? So coordinating kind of some of the, I don't want to say bureaucracy, but that's the word that comes to my mind, of just getting all of the ducks in a row to put an initiative like this in place at a larger organization has posed a little bit of a barrier in, like, the Banner Health, for example, or Common Spirit, Advent, some of those larger health systems that have several primary care clinics. A lot of those have said, hey, if my providers want to do it, that's great. Let's get them trained. And so we've been going that approach with Common Spirit and Advent Health. But all in all, the ease and use of the platform has gotten really good feedback. And then the quality of the consults that we see returning with 90%, like Dana mentioned, 90%, over 90%, resulting in actionable guidance that can be carried out at the primary care clinic, you know, just speaks for itself. It's saving time for both the patient and also getting that patient closer to a treatment plan that might be supporting their medical need. So. And I'm looking for the links to the 2 CME sessions, so I will get those put in the chat as well. Thanks for the question, Rich.
I have one more question, and then I know we need to probably move on to our other topic, but I was just thinking about this. I don't think I've asked this question thus far. Do you have clinical pharmacy available as an eConsult if providers are looking for kind of next step medication options, or is it all medical specialties?
We don't currently have clinical pharmacy available, Carrie. Emily, I'll just punt that to you to see if that would be something to consider.
I feel like we talked about it like really early on, but we can definitely look into that. Do you have any use case scenarios that you could send over to us that might be helpful?
You just mean examples of? Sure.
Yeah.
I use them all the time.
Oh,
But we have integrated clinical pharmacy too. So yeah, happy to follow up about that. And we could also think about pulling clinical pharmacy data from integrated clinical pharmacy within CU system to see if data from there might help inform if that might be helpful to add at a state level to these other practices.
yeah, that would be great.
Cool. I'll follow up with you about that too.
Thank you.
Just real quick, one of the things I think I got from Heather is there's a dissonance or a struggle with providers out there on return on investment, providing top quality care, and return on investment of throughput of patients. It's a struggle out there because it does take extra work and extra time and resources to engage with eConsults. And you have 100 patients waiting outside, and you're trying to do eConsults. It's a struggle out there. So it seems like that's an issue.
Yeah, I think in some of our smaller practices too, you know, the front desk person might also be the medical assistant and the office manager. And so, you know, it's the wearing of multiple hats in primary care, right? How can we create efficiencies by having staff help support the providers in their ability to draft the eConsult on behalf of the provider? They can add the supporting documentation, but they are creating a use case, right? The specialists are using the information that's provided, so it does need to have, you know, a little bit of information so the specialist can provide a comprehensive result. They don't have the ability to look at the patient's full entire record, so it is important for the provider to put in the few minutes that it takes for them to draft the eConsult and provide that some supporting documentation so that they can get good clinical guidance that they can follow up with. So again, I think just one of those things of give it a try, see what you get from it. And most folks have felt that it's been worth their time when they've submitted the eConsult because they're getting good feedback that they can follow up with then for their patient.
So the access to specialty care group leadership, I should say, is going to be focusing on a guide for patients for specialty care referrals. I will be very transparent in that I did have AI help me a little bit in just creating something for folks to react to. So here we're just going to step through a guide to specialty care referrals. Bobby, if you're able to multitask and take any notes while we discuss it, that'd be awesome. And then I commit to having one-on-one meetings with key stakeholders that are on this call and not on this call to help move it along. Rich and Carrie, do you have anything to add before we go through?
I think this is important. It's kind of like what we did with Rural Health Access at the time called the Rural Health Access. nowhere to go was when people are very sick. Do they go to the emergency room? Do they go to make an appointment 5 days down the road with their primary care? Or do they go to urgent care? And I was surprised that many people did not know that there was urgent cares, and that the emergency rooms that were pop-ups were not really for urgent care. So we helped clarify that. What we're talking about is know what to do if you're giving a specialty care referral and you have some challenges in that. And from what I hear in the community, for those who are on Medicaid, there are many challenges, both with the ability to even get an appointment, period, to get on a list, and then longer wait times relative to those who might be on a more private and more reimbursable insurance plan. So it's something that really has been needed, I think, for years, because it has been a struggle for so many people. So it'll be kind of a know what to do, guide to specialty care referrals, and that's kind of the foundation of this. So I appreciate Mandy's AI supported guide. Thank you, Mandy.
Sure. So I think there are 6 numbers on there. Did I cut somebody off? Go for it.
Oh, it's me. I was just gonna say too, this is just to add even a little more context and not too many ideas, but just to say this is draft 1. And so what we're looking for is what are key pieces of information that patients should know that are missing here. And I think our whole discussion about eConsults and realizing that is another way to access specialty care information is really important. So if we were, so as you read this, just think about what other information should we try to present on here. And then also as we go through edits, if you have other stakeholders that you want to make sure you think we should be talking to inform what should go on a patient kind of education tool, please let us know. Or if you have ideas on getting patient input or dissemination, please let us know as well. I was messaging Mandy directly that I know there's, again, I just know the people I know, the Practice Innovation Program at CEU, School of Medicine, does a lot of community partnered education work, and they use this tool and facilitation method called bootcamp translation to translate existing evidence or information such as resource navigation information. It's a method for translating that information into patient centered information or methods. And so I do think maybe if there's a way for us to get a little pilot project funding or something, once we kind of land from here, maybe there's a way we could, once we populate with more information, we could bring this to community. So I'll just say, like, if you have ideas riffing off of that as well, please let us know. And yeah, this is just step 1, and acknowledging the system is complex and will continue to be complex, but also we could be better bringing what we're talking about on these calls to patients themselves so that they kind of know about the work and know about the innovation and think about specialty care in different ways, just like we're thinking about it in different ways.
Thanks, Carrie. Thanks, Rich. Yeah, if anyone has contacts that we should be talking with in the development of this, you can drop that in the chat or come off mute. We're not here to wordsmith anything. This is broad, high level discussion. And then as we go along and continue to improve it, wordsmith away, but we're not quite there yet. So at the beginning of the specialty care guide, we'll explain what it is. You can go down scroll down a little bit, Bobby. Outline what happens after a referral is made. So is it on the patient to make contact with the specialty office? Will the specialist office ask, does the patient need to be following up with primary care to see what those next steps are? I've experienced as a patient both of these. So, and then any required documentation or prior authorizations before making that appointment. I meant to say, I think we're intending for this to be tailored for Medicaid members, but that's up for discussion too. We could include all of that.
I think that's that the patient may need to call or schedule the appointment, him or herself. If that happens, then sometimes more often than not, the patient's really in a bind. If the primary care provider cannot or is not willing to go to bat for that patient and do the work, then if it's on the patient's shoulders, which I understand from talking with communities, too often it's on the patient's shoulders to try to get that specialty referral. And the primary care is just waiting for that patient to get the appointment. So part of that may be, but how can we get, if that's true, and maybe that's all urban legend, maybe 90% of primary care providers are working hard to get the specialty care connection for their patient. But where that is not happening, what support then can the primary care patient expect out of primary care? And if it's not coming, what to do?
Just pausing for any other input around this. Yeah, and while that's coming up, I'm currently a Kaiser patient, Kaiser non-Medicaid patient, but I know there are a lot of Medicaid folks that are on Kaiser, and their process is if you get a referral through your primary care that pops up on as a referral with steps on the app or in the patient portal to then just make that appointment. I don't know as readily what the CU Medicine or the UC Health process is. I believe Children's calls you, but I can clarify that too.
I think it happens in a lot of ways, and Rich's comment around what to expect is like what to expect from the health system or the clinic side, but what to expect and what might you need to do from the patient side. I think we like come at maybe this education tool with like both, because I think are needed sometimes to get at that actual referral.
And I wouldn't expect in this tool to say, this is how UC Health does it. This is how Health One does it, because it's going to change as soon as you type it in. Okay. Staying high level, Bobby, can you scroll to the third piece? Thanks. How to schedule your appointment. Step-by-step instructions, such as, thanks, ChatGPT, contact information, what information you need, and then how soon you can call for that appointment generally, and then what the expected time frame. I don't like for making the appointment, or like if it's like call right now or call next week, and any guidance there.
And then with that is you contact the specialist and there's no openings. What to do?
Bobby, can you type that? Sorry, everyone, I'm without laptop for another week, so I'm unable to share my screen.
And this is a big issue with folks on Medicaid.
Yep.
I draw a distinction. There's low income insurance available through the ACA Silver plan that is very inexpensive care, but those on Medicaid which is considered minimally, what is it? Minimally essential care, those on Medicaid do not qualify for the cost sharing silver plans, and so they're kind of stuck. And so what do they do if they have what was the top issue? It's not neurology, but the top issue of within eConsults. But we have one of those issues, and it's on your shoulders, and you're a Medicaid patient, to get a specialist to treat you for it, or at least to talk to you about it. Then you're stuck. Whereas if you had the silver plan, most specialists will accept them. But is this when I say most specialists do not accept Medicaid, or accept them only to a limited degree, like a small number, is that a fairly accurate statement in your guys' experience?
Rich, can you restate that and then directly who you're asking, I guess?
Well,
I got lost.
I'm looking at provided, the one provider I see out there is Carrie, of course, and there may be others, but also within HCPF itself. The question is, if you're on Medicaid and you need, let's just talk about one of the top 5 specialties that were listed from the eConsult program. If you need those high in demand specialty access, if you need that, are you much more likely not to find a provider that is willing to accept Medicaid than finding a provider that will take you because you are on Medicaid? Carrie?
Maybe not necessarily, but I will say, I'm going to respond, but also know we're sensitive to time, and we typically lose people at the 10-minute mark. So I would say, we know certain specialties are more of an issue, but whether or not that's just because we have increasing like population level needs versus there's less specialty appointments in those particular specialties. Like I would say usually there's maybe a little bit less. Access is more of an issue, but yeah, but I think broadly, if we're talking about this kind of feedback document for patients, I think what I'm hearing from you, Rich, is we should make sure that this, this patient education initiative includes what are the available options, even if they're not great. Emily, thank you for your comment in the chat for what are their tools that if they are asked to call and make an appointment and they can't, and they are told there's no appointments, what can they do next? And I think what you're like being asked to put on a wait list, great. Maybe going back to their PCP to ask for referral to a different location. Maybe it's that. Yeah, asked to see if they're being preferentially scheduled into an MD visit and they could see an advanced practice provider. I think those are great ideas. I will go ahead and say now, I think thinking about specialty care and how we educate patients about specialty care on this tool to include more than in-person visits and say, is an eConsult available? Could you place an eConsult for this question rather than an in-person referral? I think that's kind of a new frontier, not frontier defined by less than 6 per square mile, but yeah, I think that as well. How can we help educate patients that eConsults are available and help them advocate for themselves to get an eConsult potentially? I think that's something completely new that hasn't been tackled yet. It came up recently at the kind of a Colorado community partnered equity conference I was at that I think some folks on this call maybe were at, or representatives were HCPF were at, and we were kind of having a discussion about this too, is how do we help patients understand what an eConsult is?
All right, keeping with time, we have 3, we're halfway through.
Great.
And then I know we'll make sure to save stuff that's added in the chat and add it to this and clean it up before next meeting. Bobby, if you wouldn't mind scrolling down. This is like really a good exercise for a control freak like myself. I can't control the document. Okay. Insurance and authorizations. Is this tracking for people?
Yeah, I think we'll need to tell patients what a prior auth means. That's a very
Yeah.
technical word, but yeah, but letting them know sometimes authorization is needed.
And just confirming that's the case for Medicaid populations generally.
It's
Or
not
no?
always,
Not really.
actually.
Not
It's-
as relevant, maybe.
I would say if we're focusing on Medicaid, I don't think so.
Okay.
Emily,
Yeah.
do you want, yeah, comment?
I know for like specialist appointments, you don't need an authorization to see a specialist if you're on Medicaid. That's been
Cool.
covered.
I will
Cool.
say, sometimes the issue is that in order to accept the referral, a receiving clinic wants you to send records.
Mm-hmm.
And that turns out being a hiccup, because they're like, can you send me all the labs and every note that was pertinent? And I'm like, oh my gosh, now I need to go through all my notes from the last 2 years and pull out just the ones that are pertinent. So I will say that ends up being a step. So helping patients understand, sometimes that's what your provider has to do, and that takes time, could be helpful, and sometimes that's a step that does need to happen.
Okay, scroll down to number 5, please. I'm typing in the chat something. Okay. What you should bring, questions asked. I think this is probably beyond probably beyond the guide, but if you all think it's relevant for this, your providers. And having GPT do the initial draft helps me to like not be defensive of anything that's on there. So if you say slash it, we can.
Why don't we scroll to 7? I agree
Okay.
that I think like after the appointment is less pertinent. I think if we're just trying to help patients understand what's available for specialty care and how they access it and how they kind of advocate for themselves. Oh yeah, insurance or billing, that's really good point. Since we're getting close to the hour, do we want to pause and ask and just say, like, from those who have not come off mute, anything we should be who else do you recommend we talk to?
Yeah, open invitation to step forward if you haven't. Or step back, I'm saying to myself, to allow other people to talk.
Well, I think one recommendation that would come out of all of this is that we really need to take our specialty care list, which you could find at the website, Find a Doctor, and then make sure that it actually is accurate. Because my understanding, if people try to use that, they will get a specialist who's listed as someone accepting Medicaid, but no longer accepting Medicaid applications. So what can we do, maybe working with HCPF on that, to invest some resources in a listing that is actually usable and not a waste of time.
Hear you, Rich. I think we talked about that last call. And we were informed that might be an aspirational goal, but I think setting big aspirational goals is important because eventually maybe we'll get there.
I remember that as an aspirational goal. And actually, since Aurora Health Access back in 2009 has been existing, it has been an aspirational goal of the Aurora Health Alliance. So something that we need to support and encourage on getting some resources. I know within healthcare industry now, a lot of resources are being cut, but this might be a good one to consider.
Does a primary care provider or office typically have input or any guidance on what kind of specialist or where? Is that something we should look into, like a community primary care provider? Are they going to say, hey, go to UC Health, or do we know?
Usually just whoever will accept a patient. And the, from a PCP's perspective, my answer is always, I'm so sorry, I don't know all the insurance networks and all the specialists that are accepted in your network. And so I think that gets at Rich's issue, right? Like transparency around networks and things like that is a little tough. I think depends on the practice, who knows? Usually on a practice level for Medicaid populations, someone is trying to keep a list. And usually, like for instance, at Stride and Aurora, that's the care coordinators, but yeah. And maybe there's some information on here that needs to be yeah, I think that's where like going back to the PCP just feels like the right place, because the PCP will know who in their practice is the holder of the best list.
Okay.
The PCP themselves usually. So Mandy, I know that Jamie from Colorado Access and Care Management from Colorado Access isn't on the call, but we plan to follow up with, just so you all know, we plan to follow up with them to get kind of input on populating this.
Carrie, we're in sync. As I was typing that in the notes, you said it out loud. That's so cool. Awesome. I think AHA staff and access to specialty care facilitators and co-chairs, if you can give us like a thumbs up to keep going, I think any encouragement on this project will help us to keep going. I'm a millennial, so I need that trophy for participation to keep going if this is a good project, but
No, I appreciate what you did is in generating this guideline. It really gets us started, and it gets us into conversation, into areas that may be aspirational, as Carrie says, but nothing ever happens unless we actually do something, even though it may seem difficult or impossible. So I'm thinking this is something that we truly need to come up with, is at least guidelines, or know what to do out there. Because I tell you, out there in the community, if you are very, very sick and your provider says you'd better see a specialist and you can't get a specialist, that is an awful position to be in. And it's out there. So something that we really need to work on.
That's one as another key stakeholder. I was wondering if the HCPF Safety Net Connect folks on this call have talked about patient-facing information, about educating them about eConsults. Has this been in the conversation? If not, anybody want to volunteer to follow up with us to talk about it?
So we've been working with Emily and Dana and Andy, following HCPF's guidance on patient-facing material, and so far that has not been a direction we've gone with HCPF, but I think that it's a future consideration. So Emily, if you want, I don't know if you have anything else to add, but at this time we're not doing direct patient outreach.
Yeah, I mean, it's come up in conversation a couple times, but we haven't really put any member-facing documents together. I think like one of the questions I have is like, how would you get that out to members? There's just a lot of open-ended questions that like, okay, well, we put this together. Where does it go? How is it distributed? What if there's a clinic that's not using an eConsult platform at all, but the patient wants an eConsult? So there's just lots of different moving parts. in questions. So I think that's part of why we haven't put anything together for members.
I think maybe if a Medicaid patient's asking their provider for an e-consult and they haven't come online, maybe that'll help them come on to the platform. I like that.
Yeah.
Well, if we do continue with this, I think we're not trying to force anything if there's not good momentum, but it seems like educating patients about kind of what the resources are, where they're at, seems like a good idea. But if we do move forward with this, it would be great to have someone from HCPF or just to kind of inform us of like what your questions and considerations are if we were to move forward as a coalition on this. So let us know who would be the right contact.
Sounds good. Yeah, it would probably be me.
And again, this is going to be a guide for patients to use and for primary care folks to know that the patient does have steps to follow, and, working together, closer together, the patient and the primary care provider to actually get that referral and get that connection, whether it's through e-consults or but something so that patient is not just out there all alone. Because I have in my community, I've seen patients out there all alone, begging for hospital to hospital for specialty care, and if you, oh my gosh, put yourself in those shoes, and you know what I'm talking about. This is why I think we need to continue this.
Sounds good. Thanks everyone for joining. We will follow up, and then we'll be squeaky wheels on squeaky wheels to help get input on the very basic Chat GPT guide.